Okay, noting that it's 7:03 on January 19th, 2022. First is have a roll call kind of attendance for the meeting because it is a remote meeting. So, Daryl Beardsley present.
Matt Beavers present.
Lisa Camp present.
Matt Vitale present.
Okay. We don't have any formally scheduled hearings or other appointments, but we do have a number of items to cover, and it's on the agenda. And Matt, would you like to kick off with the COVID-19 update?
Perfect. Do we need to add the items for the?
Oh, yes. Thank you. I felt like that I was missing something. All right, but before we do that, there are a couple of items that were not reasonably anticipated by the chair 48 hours in advance of the meeting, and we can vote whether to amend the agenda with those. And one is we received a COVID-19 policy updates from the ECDC nursery school, and then we have a number of permits.
Hey, Daryl, you're going in and out, and I literally can't hear you now.
No, you're still inaudible.
Yeah, I can't hear anything, Daryl.
Okay, so still not hearing me?
No,
You sound very far away.
Yeah, you sound like you're talking through a cone.
Oh yeah, I've got one of those big dog cones on. I don't know what's wrong with that.
So Daryl, I can.
I'm going to stop sharing. I'll let you do that, and I don't know what I'll do. Maybe I'll phone
Perfect.
or something.
Okay. So let me. So we do have a motion for approving the ECDC COVID plan and the 2022 disposal works permit.
So moved.
A motion to add them to the agenda, I assume, not to approve them.
No, you have to approve adding them, and then we take
Yeah,
it.
I think Matt just said, do we have a motion to approve them?
Oh,
I'm just that excited. I like to add them to the agenda.
Okay, sounds good. I would move that.
second.
Second that. Daryl, aye.
Matt Beavers, aye.
Lisa, I.
Matt Vitale, aye. And then I can sort of share the screen for the data updates, and then I see Ali here from ECDC, so maybe we can do that one next.
Sounds good to me.
Do you guys see the PowerPoint?
Yes. Yes.
Perfect. All right. So again, I think this data will be familiar to most folks on the board, but just to kind of review as we've committed to doing. This is the average daily rate, which is Dover, Sherborn treated as a combined community is the red line. So our case rate was 193.2 per 100,000 per day for last week's data, which put us still below the state level, but much higher than we've been at other points in the pandemic. Our testing rate has remained robust and really at some of the highest levels we've had throughout. Of note, this just is the PCR molecular testing. This doesn't include any home testing that people are doing with antigen tests, and the same is true for case rate, is it just as molecular test results are what's counted in that total. Our positivity rate is quite high, suggesting that access to testing remains a barrier and that there's likely to be uncaptured positive cases due to the availability of testing. And this is our combined cumulative case count for Dover and Sherborn, where again, we see that the difference, even a couple of weeks, is several hundred cases, which is really different for us than at most other points in the pandemic. This is a similar view. I think that what's helpful about this one is it includes last winter's surge. In this one, the state is in blue, Sherborn is in, I think it's orange, but like colors are tricky, and Dover is in gray. And so
It's orange.
Okay, perfect. and Dover's in gray. And we really see that, you know, our last week's data at both the state level and the local level is about 3 times higher than we were at our peak last winter. So again, I think the experience of feeling like a lot of COVID is going around is validated by the data that suggests a lot of COVID is going around. This is the New York Times visualization, which I think is a nice cut of the data, which this is the data reflecting. I'm on a meeting. Okay, good luck. Jake's expansion pack is still loading. Oh, that's good. I'm on a meeting, buddy. And so the trends in Massachusetts, we do see that cases have started to come down. Hospitalizations look like they're starting to plateau. Testing volume is relatively steady, and the death rate is up, but lower than either of our 2 previous surges. And I think the wastewater data in some ways is the most encouraging in the context of inadequate access to testing. This data is the concentration in the samples. And so even if you don't have testing, this data will still kind of track correctly. I think that this is vulnerable if for some reason Omicron is present at different levels per case in sewage, you know, that could change it, but it's not sensitive to testing. So again, I think encouraging signals that align with what we're seeing with cases. This one is a slide shared with permission from a local presentation where I work, and I think really highlights the importance of boosters. And as we think about what level of protection a community has, I think that what we're seeing is that increasingly primary series sort of isn't the key punchline. It's really the booster, at least as it relates to cases. Across the board, we still see reasonable protection against hospitalization and would suspect similar data for ICU and death. But for primary infection, you know, booster is really the key to protection, and primary vaccination is relatively limited. I don't know that we can necessarily extrapolate this to the kids who are age 5 to 11, just because it's not the population that the data was observed in, but I think still helpful to kind of have as context. This data is from the municipal reporting data that the state releases every Thursday. And this I've pulled out because all of our populations have had very high vaccine uptake overall, and are sort of above 95%. And with the way the data is compiled, the denominator is an actuarial calculation of how many people should live in Sherborn in a given age group, and the numerator is individual level data. And so what we see is that we know that we've got great primary vaccination, but we still have a fair amount of variation, particularly in the 16 to 30 age range for boosters. And if you consider the previous slide, it means that we still have some segments that are, you know, pretty vulnerable, particularly if they were vaccinated early in their eligibility with the primary vaccination series. So I think that the take home for this is, you know, if you are, you know, one of the demographics who's eligible for boosting but have not yet been boosted, it certainly would be reasonable to prioritize that as we see Omicron and some of the effects around effectiveness. This is one that we talked about, or that I think was talked about at a recent Dover Board of Health meeting, as well as the joint school committee meeting. So there's a couple of testing strategies that the school and the district have stood up. The testing listed here is accessible to residents of Dover and Sherborn, or staff working Dover or Sherborn, as well as the school community, with access to molecular testing via AFC. And the school is also doing some strategies around rapid antigen testing to try to mitigate some of the limitations with testing access we've seen.
Hey, Matt, was this
yeah.
publicized? Because this is actually the first I'm seeing it, and I had an exposure. I was negative, but it was very hard. I mean, I have a lot of home tests and just played the probability game with antigen tests, but I mean, I didn't even know that this was available. So is this something that is being publicized on our website, or could we send a blast out, or?
I think it's fine to send out. I think my recommendation, so I'm not sure which pieces it circulated on. I know that within the school community it's been publicized, but for the general community, I don't know that there's been a push.
There hasn't, because I don't have kids in the school anymore and I got nothing.
You're missing out.
Yeah.
And so this will be open for until the end of the month. So I still think it's worth posting. I'd recommend against posting on Nextdoor or Facebook, just because the access is limited to kind of Dover, Sherborn, or employees thereof. And so I wouldn't want AFC to get bad press if somebody from Wayland felt frustrated that they didn't have similar access. But I think certainly fine to post on the town website, and it's certainly public information on the school side. I think Dover's posted as well. I think there may be a private Dover Facebook group that they may have posted on, and I think they posted on their town page, but I'm not sure. But I think certainly fine to do so. And I think this has been going pretty well overall. I think the testing has been popular. They've had some challenges with no-shows or with families that had signed up for multiple slots and not canceled with enough lead time for somebody else to take the slot. But overall, I think has gotten very positive feedback, which is great. And I evidently that is it. So I'm going to stop sharing this.
Matt, if you can hear me, can you hear me?
Yeah, loud and clear.
Oh, okay. If you could send me that last slide, that would be the AFC one.
Yep, absolutely. I will send it to you during this meeting.
And I'll post it on the COVID page.
I think that would be perfect. And I think it's been really, I think on the school side, there've been a lot of changes related to pool testing and a lot of dynamic, just a lot of moving parts, especially as we've had a much higher case rate in the school-age kids in the community, not necessarily school-based transmission, but kind of community-based transmission of school-age children, where it has been incredibly busy on the district side for the school nurses and the testing side. So having AFC has helped identify a lot of additional cases, and I think has been a helpful avenue for testing siblings and family members of students who may be affected. And so I think has gone really well. Matt, I don't know if you have anything that you'd add to that.
I'm trying to remember the timeline of everything, but I don't think it was up and running by the time of the last meeting. But I think just the only thing to add is that the school is also offering every day drive-up symptomatic testing for students only. So not to the community at large, but for students. And so I think there's been relatively robust use of that as well. Really is a strategy to lower the barrier to testing and keep symptomatic kids out of school. And it seems like that's working well. I think my only other sort of general comment is we've got now a couple days worth of declining COVID census in the ICU. So I'm hopeful that we're sort of cresting the wave here.
Yeah, I would echo that on the floor service. We're seeing a net decrease, and it sounds like on the employee infection rate, we're seeing a significant net decline. So again, I don't want to jinx this, but I'm hopeful. But I do think access to testing in conjunction with, robust vaccine uptake is an important part of the strategy. And so maybe if there's no other comment on the data piece, maybe we can kind of pivot over to the ECDC COVID protocol, if that works okay. So I'm happy to sort of open on part of this, and then Ali, if you've got anything to add, I would sort of welcome it. So I looked at this, and I think Matt looked at it, and then I also talked to Alyssa about it. And I think our general sense is that the protocol is provided sort of meets or exceeds the state requirement, which I think is certainly reasonable. And I think really focuses on leveraging testing access to try to keep kids in school and recognizing for preschool kids that testing is, I think kids are good with masking. I suspect that younger kids having good testing makes it even easier to have another layer of resilience. And so I think my own opinion, sort of looking through it, is that I thought the protocol seemed reasonable and prudent, and I was supportive. And I think it's really just a question of, you know, kind of working with the state to make sure that there's testing to support it. And Ali, that piece I'm a little bit less expert in terms of what the state's communicated to you guys about what will come next, but certainly the protocol itself seemed reasonable to me.
Thank you, Matt. Just today, the state released some new information. So ECDC, working with the Board of Health, has already made significant gain in getting ready for a test and stay situation in the preschool, similar to what DESE has been offering. We have been utilizing pool testing for a few months through EEC. And now we have our large orders of rapid kits coming in, and the state just changed protocol and will be offering rapid kits, COVID testing kits as well, starting January 31st. We should get our first shipment. So just today, the state kind of changed things up a little again on us. But what we've written as policies is still in line with what they're recommending. And this is really for close contact in school to provide a healthy environment for kids who are able to attend. We've kept pretty stringent guidelines for in-home COVID cases and requiring students to remain quarantined at home, because we certainly don't want to introduce COVID into the classroom if possible. But between pool testing and rapid testing, I think that using both testing tools has been efficient for us.
I think that sounds awesome. And I would really echo, you know, what we like, the term we use is secondary attack rate for how likely is a case of COVID to generate another case of COVID. And what we know from both Omicron and for previous variants is that the risks associated with household contact is a lot higher than community contact. And that's likely related in part to masking behavior and just total number of hours. So I think limiting it to school contacts makes sense. I think if there's similar community type exposures and there's a testing infrastructure that you guys have that can support it, I think that's reasonable as well, but I wouldn't include household contacts, at least at this phase of the game, although I'd sort of be happy to talk about it in the future. I just worry about the household more, but it sounds like that's already where you guys are at right now.
Yes, absolutely. I agree. The household contacts is difficult to manage for any family with young children.
Can I ask a question? So my daughter lives in New York, and she is getting her master's in social work. And as part of that, she works in a middle school in New York City as her field program. And I don't know how this differs, Matt, from like the Massachusetts Department of Education, but with Omicron certainly being the dominant variant, certainly in New York City, and I presume as well now in Massachusetts, they have altered the amount of days for asymptomatic people. And what the Department of Education is doing in New York is that if you are positive on a PCR, but asymptomatic, and after 5 days of isolation, test negative with an antigen test, they are permitting those students and teachers and staff to return to school. So I'm not advocating that ECDC makes something less lenient, I mean, more lenient than it is, but I'm just sort of informing about what the New York City Department of Education policy is, and if that's something that, you know, people care about or it matters.
I think Ali alluded to it earlier. What I would say is, at least on the DESE side, which I'm more familiar with, and I imagine EEC is kind of the same, is that there's just lots of changing guidance, like so much. And that just when we kind of feel like, okay, we've got it, they're then like, we have slightly changed the rules, and you kind of chase your tail again. So I suspect we'll continue to see some evolution in their guidance over the next couple of weeks. And I think, you know, with the antigen testing to Omicron, there may be differences in how the tests perform, but I also think the way that I think about the testing is it's one of many strategies to try to keep the classroom safe. You know, I'm enthusiastic to see ECDC able to add that as well. And I think we'll probably continue to see some evolution in the isolation requirements over time.
And actually,
I would-
EEC has changed it, so it is that 5 days and you can return after. We have kept the program so that we're still requiring a 10-day quarantine if a PCR or a positive test comes to fruition. Mask wearing from that days 5 to 10 is very important in the early childhood education. All of us are wearing masks in school, but certainly 2, 3, 4, and 5-year-olds, it can be difficult. And there's, you know, reminders and helping adjust mask. And also we have quiet time, snack time, lunch time, and those are all unmasked activities. So our main goal is to, you know, not bring COVID into the school if at all possible during that continual contagious period. But EEC has lowered that guidance to 5 days, and if negative on a rapid antigen, that they could return.
So I was going to say basically the same thing, that I think the issue is masking after day 5. That you know, that would be consistent with CDC guidance. Day 5 you could return if you can mask, but I think with these young kids that's going to be difficult. I also would argue we probably don't necessarily need a negative antigen, which is not required by CDC on day 5. But I think if we're staying out 10 days, that just makes sense. And I think if you can't mask, that makes sense. I had a couple of questions about this as well. I think one would be, some of it was just around sort of what's required to return for symptomatic kids who test negative. And I guess one question is whether we really need a PCR or whether an antigen is adequate, just given limited testing access and really relatively effective antigen tests if symptomatic. And then I think the other question is whether, it was a little bit unclear, I think just because of commas, whether kids are required to actually go to the doctor to get clearance to return if they're asymptomatic and have tested negative.
So we did keep this pretty stringent. EEC does have drive-up testing available in Franklin. Most of our families have found a pretty decent way to be able to get PCR tests, and we're going to keep kind of evaluating that. EEC just put out new guidance today again, but also with the lack of ability to get test kits, we're just getting our first large shipment in this week, and I have a stockpile in the office. And with EEC, will be supporting us in about 2 weeks. We should get our first shipment. With the pool testing for children that have been asymptomatic, I've also allowed them, if they're still at home in quarantine, to kind of drive through and participate in our pool testing for families that have had a difficult time finding PCR tests. We started a little bit with the flexibility with the antigens. I think it's also the comfort level of our teachers and staff. They've kind of been used to that gold standard of a PCR. So we're starting to introduce kind of the new guidance that has been coming to say the antigen should be used as well. Again, just for the sake of parents having access to it.
I also think the performance is reasonable. And so that's fair, but I completely understand. But I think, and then the second question was, are we actually requiring kids to go into the doctor if they're asymptomatic to get clearance to come back?
So we have had children going to the doctor if they're asymptomatic. We have not been as stringent. I've kept very close record of every student, obviously, that has COVID, that has been COVID positive or has had exposure, or if there's cases within the household. Just until today, EEC required us to file reports on our lead porthole to our licensing, as well as create DPH reports for every single child and every single house member for every child that had COVID cases. So we're constantly kind of looking, and we're going to probably make this a little bit more lenient with the testing requirements of allowing where it says PCR to allow more antigen testing. We're going to continue to pool test for all students that are, willing to participate, because for Neighborhood Village, the partnership that EEC created, it has to be a volunteer process. And unfortunately, coming back from vacation, we had a number of students that, recently recovered from COVID for positive cases. So they are ineligible at this point right now to participate in pool testing.
So I guess my question is still specifically about sort of the symptomatic student where it says they can return after symptom-free for 24 hours without fever-reducing medication, be seen by a medical professional, receive clearance, and a negative PCR test. And so I guess my question is, if they're symptom-free and have a negative test, do they need to go see a medical professional and have a note from a doctor? Because I'm not sure that's necessary, and I'm not sure, I think it may just put undue burden on pediatricians' offices.
That's something that I probably can remove at this point. Again, the guidance was very recent that EEC changed things for us. And today they just put out new guidance and protocols as well. They're much more lenient than what we are comfortable with ECDC and what our board of directors is comfortable. Again, our goal is to have healthy students being able to attend school. And we're trying to bring down some of those barriers. And it is a fine balance between the comfort level of teachers as they get adjusted to these new requirements, because they're concerned with their own health and possibly being exposed and their family members. So it is something that we can look at that area. And
I mean, I think that's fair. I just think it's silly to say you have no symptoms, you have a negative test. Now please go to the doctor and have them write that on a piece of paper. I don't think that changes safety. I think it just creates barriers for everyone. But I mean, I agree, like you need a negative test documented and you need asymptomatic documented, but I think there's nothing that a visit to a doctor's office adds to that. Was really my only comment.
Absolutely. Thank you.
And
So maybe the doctor's visit would be if a test could not be obtained or something else.
Yeah,
I mean, I guess if I'm just trying to understand what the need for the doctor's visit is in any situation. Like if they test positive, they need to isolate. If they test negative and they're asymptomatic, if they test negative and they're still symptomatic, it makes sense to go to the doctor to understand what's going on. Does that make sense?
Yeah, and it's really the doctor's note is really for the symptomatic with negative. And
like
again,
it's like if the doctor's saying this is strep throat, you're like, I totally want to see that before we have the kid with the sore throat that's still a little tickly coming back in school. Is that sort of the scenario, Allie?
Right, because even for EEC, anytime there's things of strep throat, conjunctivitis, those type of illnesses, we have to notify all families that they are within the program.
So maybe these conditions aren't additive, it's more a mix, a possible mix, depending on the exact circumstances.
Yeah, I think that makes sense. I think flexibility makes sense. I just don't want to see us in a situation in which we say the kid is totally better and has a negative test, but you need a doctor to say that that's true. Does that make sense? But I think if symptomatic was something else, then that makes sense.
Right.
So
we haven't had many illnesses till this year. Luckily, last year there was very few illnesses, and just the nature of more exposure over this year, there, the sniffles and sore throats and things like that start to come about.
So if you're, can you scroll back up? I guess I'm confused.
Sorry.
Following Matt's thread here. So no, keep going up. So symptomatic individuals will be eligible when symptom-free for 24 hours without medication and be seen. Like, so I guess, yeah, I am a little confused about that. So,
and this is us adjusting to kind of this new guidance, because prior to EEC had much stricter guidelines for us to follow. And if they were symptomatic and at the time, we also didn't have as much testing opportunities because we're just bringing rapid testing into the program. We only had the option for a weekly pool testing. If a child had symptoms, we really needed them to go to the doctor to receive that testing and to have clearance to come back.
And so
yeah, I guess I'm just saying that like going and now at this point they could go to AFC and get testing, right, and be negative. And because we have those other options available, I'm just trying to provide them other options other than just their pediatrician's office.
yeah,
Maybe there's room.
Yeah, I agree.
Maybe there's room for an and or type of
That's what I
series of
that's what I was
conditions.
thinking.
And that way you could decide Ally, with the parents about what matches up with their situation,
And
their
so
child's situation.
And we've
guess
tried
for-
to be flexible with parents for this because we want kids in school. So whether it's participating in our weekly pool testing, a child today had slight, maybe congestion. Mom said, I had a rapid, test. It was already negative. There was no other symptoms. We definitely want our kids who are healthy to be in school.
Mhm.
And so it sounds like what I'm hearing from the board is it sounds like we want to say, like, one, like Ali, I think it's, and if I'm misrepresenting it, feel free to correct me for anybody on the board. I think what we're trying to communicate is this is a place that we think there may be some wiggle room. If you and your parents and your faculty feel like this is an important thing to keep us safe, that's sort of a separate question. I think for us, the piece is doesn't feel like it has to be an always. And I think the other thing we've heard from the pediatrician who works on us with health and hygiene is just how busy those offices are. And so to the degree feasible, if it sort of passes your gut check and makes sense, it seems reasonable to us not to require it, in part because it's probably not adding safety. And I think there's part that's also just, that visit and that time, maybe a time another kiddo can't get in to get seen when they are symptomatic. And so trying to balance those on the macro scale, the doctor visit part, at least to me, feels like the least important piece of it. But again, if you guys have specific situations, that also sounds reasonable. Does that sound right to folks?
Yeah, I think so. I mean, I think if a kid is persistently symptomatic, it makes sense to go to the doctor. I think if they're not, I just want to make sure there's flexibility. Because what I don't want to do is have a kid who's healthy sitting in a waiting room full of sick kids if he doesn't need to be, right?
Absolutely not. There's a flu and everything else that is in there waiting to get to them.
The one
Yeah.
other thing I wanted to mention is that, one, I think it's great that you prepared this. I also did note that, right, you've gone for more protective measures at the school. And so really, I can't fault going beyond the bare minimum. And I just highlighted this because I also want to thank you for working our public health nurse on these issues to understand them and to figure out ways to address it and keep things in a good way for all the kids at your school. So,
Hey,
thank
Daryl,
you.
you still
I'm
sound-
breaking up again. I just got a message.
Yeah.
Yes, the update seems to have affected a few things on my computer. So, perfect.
Ali, is there anything else that you or the ECDC community needs from us as you kind of roll this out, or is there anything else we can do to be useful?
No, everyone has been wonderful. Alyssa is wonderful. The public health nurse has been wonderful to work with. And we appreciate your time looking at this.
Perfect. And Ali, is your sense that we need to vote and endorse the policy, or is it just the sort of discussion tonight? Has EEC communicated what's required?
EEC's requirement was that we worked with the Board of Health. Today, they just put out new recommendations, but we still wanted to talk this through with everyone because Alyssa, Matt have spent time on this with us. And until we get that rapid kit supply from the state, we're going to go with what we have been working on.
I think that sounds perfect. And so rather than sort of voting on a specific policy that then I feel like makes it harder for you guys to change, we've sort of gotten this feedback and then are certainly happy to work with you if issues come up.
Thank you, Matt.
Thank you, Allie. Okay, so if you can hear me well enough.
Yes.
Yes, okay. All right, we do have one more COVID item. The request for vaccination mandate for town employees.
So I know we sort of briefly discussed this last week. I don't know, Daryl, if you sort of had a vision for how to proceed. Do we want to kind of have each person go around sort of in whatever sequence and kind of give your 2 cents about how you're thinking about it? Or
Yeah, I think this is a complicated one, and certainly at the federal level, it's been complicated and it's been challenged. And I would like to more follow suit, and I don't think the issue has been resolved.
Yeah, so my 2 cents is, I think that the utility of vaccination is important. I also feel like it feels like an issue that being at the very front edge of can take a lot of time. And I sort of worry about
Yes.
what are the other things that we won't be able to do right now to focus on this in a community, and I suspect a workplace that's already had pretty good uptake. So my 2 cents would be to say, I think a really important issue, maybe not the one to put front and center at the moment. And I think also just understanding sort of what happens in school over time from the state down, I think could also really help inform this in terms of if the state has any vaccination requirements that come out post Omicron. I suspect they won't, but it feels like an important issue, but not an urgent issue. Although I would continue to encourage anybody who's booster eligible to get boosted. Does that sound right to others on the board?
Yeah,
Yes,
I'm not sure the marginal benefit of a mandate makes sense here, and I would like to sort of get a little more clarity from above on whether these things are going to be upheld.
yes. And really the greatest risk is for the unvaccinated,
Yeah.
at least the way things currently stand.
And there's a
Yeah.
mask mandate in the town buildings, so as well.
The other thing I'd be curious about exploring, and I don't remember what town had done it, but I know that there was a town that instead of having a mandate had sort of an affirmative incentive that I don't know if they used ARPA funds or something different, but I'm happy to track down what town it was, but it was essentially an incentive for people who got vaccinated. Again, I think to Matt's point, I suspect that the marginal benefit is pretty limited, and I'm not sure the juice is worth this piece right now, but that could be another thing to think about if as a town we wanted to incentivize it, particularly in a pretty tight job market. Coming up with an affirmative strategy sort of feels more appealing to me than the idea that we'd be potentially terminating people at a time when the job market's relatively tight. But I also think reasonable to say, you know, let's see what comes next.
PS, that's what my company did. So they didn't do a mandate, but they incentivized and gave like little bonus perks for everyone who uploaded their vaccination affirmation, which I think is a great thing.
That might be interesting, because what I was going to say, not for tonight, but for another discussion, would be whether we manage vaccinated and unvaccinated people differently, whether they come down with symptoms in terms of arrangements for work at home. I don't know if there's a different strategy altogether.
I think that's hard. I think I would have said that 3 months ago. I think that becomes harder with Omicron.
Yeah.
I think that, you know, the one could argue the incentive vaccination should be, will keep you out of the hospital, but that's probably not enough. But I think with Omicron, it's hard to say that we should be treating, you know, context differently or isolation differently or anything like that.
Okay. So I'm gathering from the comments that we really are not going to be pursuing coming up with a mandate for this evening. And wait and see. Again, I would rather that the state or federal got this straightened out on how this should be approached.
Yeah, I agree.
Okay.
But again, just to be clear, I'm wildly enthusiastic about the benefits of vaccination and the prudence of getting vaccinated. So I think for me, this is really thinking about process, not vaccine appropriateness. Like, they're awesome.
Yeah, I would second that. Very pro-vaccine, very pro-booster. In general, also not opposed to mandates and think they're a reasonable thing to do. But I think in the face of the multiple challenges they've faced, I'm not sure adding another layer onto that is helpful while we wait for the other things to get sorted out.
Okay, Mark, I know that we have a few things under agents business, and I know that some people have joined the meeting for these topics. So would you like to?
Sure. Well, if you want, we can go in order. I believe I saw a couple of people here for 74 Washington Street.
Okay,
There's a building application in for 74 Washington Street, but at the same time, there's pending items that need to be resolved before any building permit can be issued. Unfortunately, history goes that according to Mr. Canny, our building commissioner, the previous building commissioner had issued a building permit without the Board of Health review. That doesn't make it right. And we're trying to get from 9 years ago, you'll see in the letter below these emails that they needed to resolve quite a few things up there, and they haven't yet. And they're working at it. The new people are working at it. I give them credit. But as we go through this letter, we're still waiting for the quality testing for the new well. But the well apron's in place. They have the correct size water pressure tank. And then there are needs to have the new owner sign the well water agreement letter. And so we're waiting on that. And the transfer of applications. So that's for the well. And then for the septic, we need the pumps recertified by an engineer. In Discovery, when they, what happened was a septic installer was hired to do that work. And I reminded the new applicants that that has to be done by an engineer. But the installer, the septic installer, noted that the septic tanks are at grade and they require at least a minimum of 9 inches of cover. And we still need to have the covering over, that's bullet 2 under septic, the covering over the septic system resolved. Again, transfer of applications are still needed as well by the new owner. And even in this letter, we noted that until these pending items were resolved, that we couldn't sign off on the building application. So I believe we'd be setting a precedent if we change the view on this. Again, it's unfortunate, but the way we'll probably get everything resolved is by getting the information needed before we can approve a building application.
yes, I'm not inclined to set new precedent, and these things are all things that are not optional.
Correct.
And that I think DEP would frown upon us for not upholding these.
Yeah, and you'll see at the base of the
outstanding
letter.
matters.
Yeah, and I'm sorry, Darryl, I didn't mean to interrupt, but if you go down a little bit further on the letter, it notes to that part, you know, that we can issue a conditional certificate, which would be the final mature vegetation and so forth. Then we can issue the building request to, and what they're requesting is again, it's not the new applicants, but the previous applicant went ahead, did some building work and didn't even meet code under the building codes. So that has to all be taken care of. But to allow that to be done before our requirements are resolved, I think would be putting, jumping too far in advance and not having our requirements done first.
Right, and I'd like to note too that conditional certificate of compliance is really to be used not for issues that are under control of the applicant, but more for, it might apply to fully vegetated, right? Because that's going to be a
Correct, yeah.
seasonally driven, drought driven, that kind of thing issue.
correct.
And so that's the kind of thing that we would issue the conditional for. But these others, some of them don't seem like transfer of the application and fee,
Yeah.
signatures.
And I did go up and I spoke to the buyer's agent and the seller's agent on January 10th. I was at the house again. I was back there, I think, on December 1st as well, and explained that one of the more important ones is the quality testing at the tap. That's the first one, because that can, if that doesn't come out proper, then there's going to be further testing needed to make sure it's not in the water supply. Hopefully there's no issues, but it's been, the well has sat there for 9 years. And so hopefully, I told them to get the advice of a well company to determine how long to flush before taking those tests.
And actually that is for any new building.
For any new well.
confirming appropriate water quality and quantity is step one
Correct. Yeah.
for a new property. So this one is really important.
And this property has an interesting history because they decided not to build a new house there. The abutters were concerned about that. And so the previous applicant decided to just renovate the house, but went ahead and renovated without us reviewing and approving the building permit. So with that said, that wasn't this applicant. I understand that issue, but the issue really is to make sure these needed items are corrected. And so the existing house is there, but they abandoned the old wells, so they still need to prove potable water for the existing facility that they renovated.
Okay, so what are we being asked?
Well, the building commissioner sent us an email at just a few minutes prior to our last meeting, and asked if I could approve that building application to correct the issues within the building codes. And I said, I have to pass this by the board because we have some pending items. So I know he was just trying to help them out, and we are too, but to go ahead and give that permission before we have our requirements completed, I think would be jumping too far ahead.
Mark, can I just ask one clarifying question? Daryl, can you go back to requirements for a second? So most of the requirements don't seem to have seasonality issues. The only thing I wasn't sure about is in terms of the grading, are there any of these elements that would be untenable because of the current climate conditions, where sort of the rest of the project would be delayed many months for something?
I don't believe so. I mean, the ground could be frozen, but you can still, well, the issue is the tanks won't freeze, they're concrete. So getting the right amount of cover over the septic tanks should be manageable. You can still find materials that are, even in the middle of winter, that are available to place over the septic system or the septic tanks. So outside of the mature vegetation, I don't see anything here that's not possible.
Okay. And the mature vegetation is something that then could be a conditional certificate of compliance.
That is
the other piece we'd say this, things like the transferring the fee or doing the water quality testing, that's all things that could happen now.
The other one that I would bring back to the board, if it's still in the middle of winter, if this gets done, is if they indeed have, say, a couple feet of snow over the system area, the lumen seeding the loom may not be able to be possibly placed either in the middle of winter, but that both the loom and seed could be a condition as long as we know, and we do have a final grade as built on hand. So the loom is in respect related to the vegetation. So that is true. That would all be as the only seasonal issue I see here.
And
Mark, I can provide an update if that helps, Mark.
Who's talking? I'm sorry, I don't.
Sorry, it's Sean Hogan.
Oh, hi, Sean. It's just your names are on the side and not all of them show up at once, but that's up to the chair. You could ask the chair if you want to give it up. If she wants.
Yes, I was just about to ask if the new owner applicants, and I guess in your case, you're the prospective owner. Is that correct, Sean?
Yes, we're kind of facilitating some of this work at this point, but yeah, we're the prospective owners, I guess.
Yes, so I wanted to hear if you had any questions or concerns.
Well, so what we did was we got Northeast Water Wells involved, and they gave us some direction on flushing the system out based how long it is sat. We've done that for the past several days, and they took the water sample today, so we should have that result back within 5 to 7 days. The paperwork regarding like the new owner applicant and for the pH and the transfer application, that's in process and pending. I thought we would have had it back by tonight, but I expect it back any day. And regarding the septic system, we contracted Colin Mayo to come out. He's gonna get an engineer to recertify that pump. He's also going to take care of the loom that you were just talking about. When able, he's going to put 9-inch risers on the covers and bring everything up to grade. So he's starting Friday. He's been paid, contract. All these items on the bullet list are on his contract.
Okay,
like a good plan.
sounds good.
You're moving. That's good. And then I don't know, Sean, if you have any control in having the owners sign the alternative technology agreement as well as.
We also, yes, we also have those documents submitted to them, and the realtor is working to get them to sign that stuff and get it back. So,
And obviously the well application and fees and all that as well. So
they have all the documents. They're
Okay.
just in
Yep.
the process of signing them.
and I believe Ellen sent those all out to you as well. So we're trying to help you, Sean. We truly
Oh, I
respect
know.
the position you're in.
Believe me, I know. Believe me, I know. So yeah, as soon as there's, as soon as those major items are checked off, we'll obviously contact you to come out and do your inspection. And then I think at that point, that's when you could issue something conditionally.
Yeah, and in advance notice, and Colin's excellent. In fact, he'll be approved tonight for his installer's permit for this year, but have him reach out to me before he starts any work, just so we can go over that. It just makes everything go a lot smoother. So, and I'm sure he will, but just note it to him and give me a holler.
We did. We told them.
Okay,
Mark,
thanks.
I-
Sean.
Mark, correct, it's Kelly Hogan here.
Oh, hi,
Um,
Kelly.
Correct me if I'm wrong, but I think when Chris sent that email, he also talked to us over the phone. And he was basically saying, knowing in the past, they really weren't supposed to give the building commissioner the approval to let the permits for the prior owner to start work, but they did. So he's saying, can we extend the past permit that actually did go through? Unless I'm understanding incorrectly.
Yeah,
I
he-
actually have a question about that. I'm sorry, this is Dawn.
Hey, Dawn.
So my
Dawn,
question is,
Wait,
Dawn,
who's
just-
Dawn?
Yeah, explain who you are, Dawn.
I'm sorry. So I am the contractor who took over, basically transferred the existing building permit. No one at the time had said that it was never approved. So my question is, was the building permit years ago never run by the Board of Health at all?
That is
Or,
correct.
'cause I was under the impression,
No.
okay,
Yeah, it's correct, Dawn. It was never run by us, unfortunately.
because when I got involved, I just transferred that permit, paid the fee, and then the question came up of the basement. And then everybody got together on these questions of the rooms and the room counts. And obviously it turned into a larger deal. So I guess the question is, with the process is going for all of these items for the well in the Board of Health, but essentially what you're saying is I can't do any work because even though I thought I had a permit or had a permit, I now technically don't have a permit.
That is correct. Chris issued someone replied for a building application, which gets passed by us, and that's where it gets stopped because we can't allow it until these things are done. And the past history indicated that the work was done by a previous building commissioner review without getting it through to us. So indeed, we can't bless something that shouldn't have been done in the past. Or approve, I should say, something that was done in the past improperly.
And is
So-
there any way of working together in sync while we're doing the Board of Health items?
That's why I
also
brought it
doing
to the
building
board.
items?
Well, Dawn, I brought it to the board, but I can't suggest that because once I suggest that to the board and it's their final decision, then we're going to have to do this for everybody. And this sets a
Yeah.
terrible precedent for any future projects, including this one, in my view.
Right, because then you have something that looks like a completed project, and yet it isn't complete on either well or septic fronts. And that's dangerous for future residents, occupants of the home. Potentially dangerous.
And so, Don, I'm sure you've sort of had this before. I think it's less about this project specifically and more about every other project, where if we kind of can't have our gatekeeper function, then the rest of it breaks down.
Yeah, no, I understand. Unfortunately, we're finding out kind of
Late in the game.
late in the game, and unfortunately, Kelly and Sean are renting now because they sold their place. So it's just
Yeah.
kind of a bad situation because so the process to get signed off conditionally, say Colin gets over there to, the end of this week, next week, it takes him 2 weeks to get it done. then we're actually almost reapplying for a new permit, or my permit gets signed off by you, the one that's already in, I guess?
That question would have to go to Chris, but I believe, I'm not for sure what the longevity of a request for a building application is. I'm sure Chris would probably keep it in the pending mode. I don't think he would dissolve it, but you could ask Chris Canny that, the building commissioner. And the
Okay.
well app,
Because
the well,
again, we're talking about a
testing-
transfer.
Yeah, I'm not for sure. You'd have to ask Chris, but the other important part, I don't know if you were on when I was mentioning the water quality, and we were discussing it when you were part of the conversation, I believe, at the January 10th teleconference we had at the house. But that's another important part that can take a long time if the water results don't come out properly. Let's hope for the best, though.
Yep.
But they shouldn't have to pay any additional fees. Like if he paid a transfer fee for the permit, I would think that just keep it in the pending mode, like you said, Mark.
Exactly.
It shouldn't, we're not trying to be punitive or anything like that. So I think it would still count towards.
Yeah, I think they paid for the disposal construction permit fee. It's just the well application fee that wasn't paid. The transfer fee is what it was. So no, we wouldn't be punitive in our fees. No, we would not.
I had a question about the Board of Health inspection. So when the bulleted items are all completed, what sort of like lead time is needed to do that inspection?
Colin will work with me very closely. The engineer will be submitting the certification of the pumps. As those documents are received, I'll review them. So they're usually reviewed within a day or two of receipt. So it's a matter when we get the water testing results. And if they're all in compliance, then that's one big step that will be completed. And I'll keep in communication with everyone as we receive information. As it relates to the work Colin's doing, we'll work together. I may come out in between his work to see what he's doing, and he'll finalize and certify his final work as well. And so we'll update you as we receive additional information.
Okay, great.
Thank you.
Thanks.
Okay, any other comments or questions on this? Nope. Okay. Thank you. Good luck. I hope all the rest goes speedily for you.
And contact us anytime you need to. You know, we're available, so that would be great. The next one, Darrell, is 34 South Main Street. I saw Monica earlier. I don't know if she's on right now or not, but if she is, she can listen in. And then if you need her comments, she was here. Yeah, she's here again. So
Hi.
Monica. She's been working with us, and she lives at 34 South Main Street. And they'd like to put a workout room in the back. I guess it's a shed right now, and also a half bath. And the house they live in was sold, I don't know, to them or someone else, but they had to put a new septic system in. And you do have documents on it, Darrell, that show that it was, there were 3 deed recordings on it. One was to make sure it never exceeded 2 bedrooms. And it was only because the land was limited out there to put a septic and a well on that property. So the previous applicant had to put a deed recording on the house because they couldn't fit anything bigger than a 2-bedroom septic system. In the state of Massachusetts, they do require that you start with a minimum of 3 bedrooms unless deed recorded. So that was the only opportunity for this property based on the property constraints.
Right.
Present, I don't know if you can bring up the documents. They have 2 bedrooms on the 2nd floor, and Monica confirmed that they have no rooms in the basement, nor do they have any rooms in the attic. They have a dining room, a living room, and a kitchen on the 1st floor. The dining room is open into the kitchen. It's almost like a whole open floor plan. And if they show up, you'll see how it's set up. So they basically, you could say, have a functioning kitchen, that's one room, and maybe a dining room that's part of the kitchen, and a family room. So that could be considered 2 or 3, depending on how the board wants to look at it. They would like to add the workout room in the outside shed area. And to do that, that would bring it either up to 6 rooms or 5 rooms, depending on how the board sees the 1st floor in the house. The question would be, is this going to be something that the board would agree to? And if so.
So I think the last time that we looked at this, we were coming down to this being an eat-in kitchen.
Yeah, is it on the
One
screen now,
room.
or do it's not showing up on my screen. I have it here. I don't know if anyone else can see.
Oh, it's not. Oh, sorry. I
That's
might
okay.
have disabled share somehow.
Yeah, I don't see
Oh,
it.
yep, yeah, no, I see. The share
That's
went
great. I
off.
see everyone now and not the sidebar, but there it is.
Okay,
Yeah, there we go.
sorry
Darryl.
about
Thank you.
that.
Well, that's okay. And so the
Okay,
second
so
floor,
this I thought we called one, the
Yep.
kitchen and
That
the
I
eating
would-
area.
I
the
would call
kitchen.
it one as well. Yes, go ahead.
And
Darryl.
2,
Yeah.
3, 4 rooms.
Yeah.
And so the basement is unfinished. Is that why there's no room count down
Yeah,
here?
there's nothing.
Okay. And then the other, all the things I was showing while you were talking, let me just go back. So here's the plot
There we go.
plan.
And
Here's the house.
shed. Yep.
There's the shed, 2 sheds. Now it proposed to be 1, and then that space would be the gym
Yeah.
with the
and
half
they-
bath.
Yep.
So
Which
we're
has
up
been
to
able- Yep.
5 rooms. It is a funny situation because usually you can do an 8-room house with 3 bedrooms. And then you can do the divide by 2 and round down.
Daryl, sorry, you're still going really in and out. It's very,
Really?
I was about to say that. I cannot hear you
Yeah.
very well, Daryl.
can't really hear you.
Yeah.
Sorry.
So Darryl was explaining how bedroom counts determined with dividing by 2. So if we get to 6 rooms, we may have to consider a 3-bedroom facility. But when you're at 5, you can round down because it's an odd number. That's how the state works in general. And that would make it a 2-bedroom. So is that correct, Darryl? I mean, if you come back clearly, I think that's what you were trying to say.
Yes.
Yeah, okay.
So I guess.
Thank you, Mark.
I mean, I think I'm fine with it. With based on what you guys are describing, I'm fine with it being 5 bedrooms, so maybe moot, but just for my understanding, we allow up to 8 rooms on a 3-bedroom.
Correct.
How is that impacted in a 2-bedroom? Since normally a 2-bedroom is not a thing that the state.
Well, that's why, and that's a good question, Matt. In general, we use that formula, but when it gets below the 8 rooms, it's not specific. It's case by case by the Board of Health. So
Okay.
that's why I brought it to the Board of Health to determine if you would be okay with this 5th room.
Right, because if you can hear me, what Mark was saying earlier is that 3 bedrooms is the minimum now. But since this property could not support 3, it was deed restricted state. Let me go back to that. Can you hear me all right at the moment?
Not
You're
really.
breaking up a little bit, Darryl, but that's
But I
okay.
think, I mean, I guess I understand that part of it, that this is deed restricted
Yeah.
for a 2-bedroom, which makes sense. I just wondered if there was any precedent for managing a deed restricted 2-bedroom, allowing a larger total room count or not. Or if it all is just a case by case.
If I can add to that. I think they're case by case, depending on what the new room looks like. I think if we went to 6 rooms, the board may, say if that dining room was walled off and there were actually 3 rooms on the first floor, it gets difficult to say a 6-room house will satisfy a 2-bedroom deed restricted home. But in this case, it's wide open to the kitchen. So I presented to the board because they're all case by case, Matt. And
Okay.
so it's really, I don't see an issue if the room setup on the first floor stays the same way as it is. No walls go up to make the dining room a separate room. And they would still need to get to us for the septic and water work as it relates to the workout room when that time comes. But I know at this point, Monica is probably more interested in seeing if it can even be allowed. But in my view, based on the way the room count is and based on the fact that, well, the board would have to consider making sure that the house doesn't change any unless they do away with this workout room. That's the only condition I would suggest, is that the house has to remain as it shows in this building application.
So Mark, you might need to translate for me again, but my one concern is that this space here in this half bath, it looks to me to be ripe for a shower.
Good
And
point,
that
Darryl. I
would
forgot about-
really be a problem.
Yeah, I
I think.
agree.
Can I speak for a second?
Yep.
Yeah, because Mark emailed me a couple days ago, and it wasn't a secondary email address, so I didn't see it right away because I don't see those emails very often. And I just put a little pressure on my architect today because I had already required him to do a label plan
Yeah,
that was required by Mark. And I quickly emailed that back to Mark, but it was late this afternoon. I
Yeah,
sent
Monica, we
that.
do have it. Daryl, you should be
Have
able to
it?
go, you should be able to go to that, Daryl. It was.
Yeah,
Oh,
that-
yeah, hold on.
There is not really a shower area. There's a closet next to the bathroom.
Okay.
And so I think Monica,
Next to the bathroom is a closet because we need storage in that room. We don't have a lot of storage in this house, obviously, so small. So, I wish we
wall-
could, I might
Could
be
the
able
wall
to.
be moved over a little bit, Monica? Oh,
Oh,
here
there
it
you
is,
go.
Daryl.
There you go. So I don't know what the trace thing is in the center, but there is nothing there really. There's a bath and then there's a closet. You know what I'm saying?
I'm wondering if they could move the wall in the closet further into the bath, half bath, so there's no chance of a shower going in there. You'd have a
That
bigger
would-
closet too.
Yeah, that would be better.
Okay, I can ask him.
Okay.
and I think for us, Monica, the biggest thing is any room that sort of directly connects like to a shower or to a bathtub is counted as a bedroom by Sherborn regulations. And
Right.
so
I
that's why
understand.
this is specifically so important to us.
Yes.
And I would say for me, kind of going to Matt's earlier question, recognizing how few properties we have and that it's kind of case by case, I would nonetheless, I feel better about it as a five room scenario than a 6-room scenario. So I think the other thing for me is the basement being unfinished is a big part of what makes me comfortable with it. And I'd sort of flag that, although again, I know that we can deed restrict the basement rooms. But it's sort of within that gray zone. I think for me, this passes the gut check as the 5th room. The sort of description that Mark provided of the kitchen and dining area as being kind of a common use, overlapping use space, makes sense for the room count for me. So kind of sounds good with the same caveats others have said. Really can't have a shower in the clear. That can be with the construction of the space, the better. And I think that I would be pretty uncomfortable doing this if the basement were finished. And so the fact that it's unfinished helps.
Yes. Yes, it's totally unfinished. Actually, I'm sitting in the area you guys are talking about. So I'm facing my kitchen and behind me is the dining area, you see, and then there's a half wall towards the living room. So I'm in a very open area right now. I don't know if you guys can really take that in. But one thing that I wanted to add, months ago, last year, I did contact the engineer who did the septic for this house. The septic was done before John, my partner, bought the house, I think a year earlier, if I'm correct. And I contacted him and he was very good in saying, yes, you absolutely can have a half bath out there. And I sent also the email that I sent you today, Mark, late this afternoon. And once again, my apologies for being delayed with that. I gave his name there. I put his name on the email. And if you need to contact him, of course.
Yeah, well, he can, yeah, and that's fine. You can have him reach out to us. Obviously, we'll need that before any. It sounds like the terms the board brought out was no additional rooms in the house. The half bath goes to being a smaller room. The closet gets bigger. But he'll need to submit septic plans as well as a well plan. Not a well plan, a water line showing on that same septic plan. And you did use not you, but the previous applicant used Civilized Solutions. Back then it was Paul Saulnier, he's a PE, and Paul has hired Eric Dickinson. That's the person you told me that you reached out to. And Eric's our registered sanitarian and he can do the work as well. So they would probably need to reach out to me before we could approve the plumbing work in the facility. But if you want to have your architect change that half bath to being a smaller room and the closet being bigger, I think that barrier in the middle is your supporting wall is what they're showing in the middle there. I'm not a building commissioner, but I believe that might be even better to put your closet wall further in because you'll be more under the supporting beam. But again, the building commissioner will let you know that. But, submit that and conditional to the final decision of the board. I think we're moving forward, and.
A quick question, just towards the bureaucracy. So should I, he can be pretty quick also. Once I get him to make that change, can I just email this to you, Mark?
Yes, you can. And I'll ask the building commissioner to add it to the building application. And then you will want to reach out to Eric if that's who you presume, that's who you wish to use. And he's fine. I work with Eric on a regular basis, and he will design a septic plan, which I have to get to the Board of Health to show. But he'll show the line going to, I don't know if he's going into a septic tank that's there, or if he's going to go through your house plumbing. He'll have to submit all that for review by me, and then it will go to the Board of Health as well.
Okay, a question about that, because I was at the town and I'm being just a messenger here.
Yeah.
So many people I've talked to, so forgive me if I get confused. I was in person, I went to the town last Thursday, I believe. And I happened to talk in person with Chris, the building inspector, because right now I literally just received in the mail today. Everything is done, you know, conservation, building. We got the green line for both of them. And now there's just, there was like one more thing that I need to give to the building department. And then this, the Board of Health. When I asked Chris about the plumbing plan that you asked me in the email that I received for the first time last week, he said, well, because this structure, and you can look at the plot plan again, is beyond, I believe, 10 feet from the septic, you don't really need to present the plumbing plan right now in order to start building.
Okay, so I think what he's trying to say is you could put the half bathroom as a future project, you know, and just put down, you know, once they move the wall, you could put down a future project, because obviously if you put fixtures in there, you need to connect them to the septic and the well. So you need the water and you'll need the sewage. So if you want to say you want to build the workout room without the half bath for the time being until you get the septic plan in, that would be conditional. That could be possible.
No, but that's not what I want to do. So that's why I'm also asking this, bringing this up to you, because basically what I understood that you said, like, you don't need right now in order to get a building permit to present a plumbing, you know, a plumbing plan.
Monica, I think there's a, Mark, correct me if I'm wrong. I think plumbing plan and septic plan are different plans.
That is correct. That is, I was just going to say that. So yeah, go ahead, Matt.
And so the plumbing plan that I think Chris is describing is the specifics within the house of how you're going to pipe it. But for us, we still need to have a plan to say, eventually there will be a bathroom here. This is how it will connect to the septic system. So that plan we still need. And even though they're related to each other, they're different plans. The septic plan is us and the plumbing plan is Chris. Do I have that right, Mark?
That is correct. And Monica, just looking at the plot plan that's up on the screen, your connection to, say if you're going to go into the existing septic tank, you have to make sure that the connection's not more than 50 feet from its connection. So if it is more than 50 feet, they may need to seek the Board of Health's permission to get a waiver if they so wish to issue one. If not, then maybe Eric's going to present a small septic tank going into the other septic tank, but I'm not for sure what Eric's planning to do here. And then the water line can come from your house to the shed. Again, that needs to be shown on that septic plan, which is not a plumbing plan, it's a septic plan.
Okay, so that's basically, would you mind sending me an email with that? If you don't,
Sure, you know, and I'll send it to Eric as well, if you don't mind, you know, asking him how he's presenting, how he's planning to present based on our regulations.
Yeah, I mean, I'm gonna contact him probably tomorrow to let him know.
Have him reach out to me as well, Monica. We talk to each other on a regular basis.
Great. So he was so helpful a couple of months ago when I first, you know, had to ask questions, and he was really, really nice.
Good.
Okay.
So now it's up to the board to decide if they're okay with the presentation with the change to the bathroom wall.
Sounds good to me.
Yeah, I think that
Yes.
sounds fine.
Yes.
And I have no objection.
Good, so we have our direction set, so I'll wait for Eric to call, and Monica, if you can submit another plan, I'm sorry, but showing the wall closer to the half bath so that we know a shower can't be added, and if the architect has any questions on that, he's welcome to call us as well.
Of course, that should happen quickly. That shouldn't be a big problem. Thank you, guys. Thank you all so much.
Thank you very much.
Hi.
Okay, Daryl, the next one is 59-9 North Main Street. And on that one, I don't know if anyone's here. If there is, I don't know. Is anyone here for 59-9? North Main Street? I don't think there is, but anyways, I can present because it's under my agenda. The board had a quick look at this before, but we needed some updated information on it. I can let the board know that the person that works for the engineer has submitted information which came from the engineer on the ejector pump that has to be put in for the half bath in the basement. So that did come in fine. The pump details were submitted, as well as it's a force pump line that's going at 80 gallons per minute force, but it breaks into a gravity line. So you lose that force the minute it hits the gravity line. It's a 2-inch pipe that goes into a 4-inch pipe. So there should be no concern with the effluent going too forcefully into the septic tank. So that gets broken down the minute it breaks into the 4-inch main that goes out of the building. So that's okay. And he did present the total dynamic head and all that. Yes, engineering design, there it is right there. So I'm okay with that part, with the pump itself that they're utilizing, and with the gallons. See the 80 gallons per minute, about a third, 2/3 down. That wouldn't be allowed if that force was going directly into the septic tank, but it's not. It's breaking off into a 4-inch pipe and loses its pressure, gallons per minute pressure at that point. So that pump will be fine, but the issue becomes the room count. And they are adding two, so it's a 2-bedroom, and Chris Canny, the building commissioner, indicated it is a deed recorded 2-bedroom facility, but we're getting into the area of how many rooms can you have on a 2-bedroom deed restricted unit. There's 11 units up there, and they designed for 22 bedrooms. And what they have is, if you go down a little bit, Daryl, you'll see the existing floor plan. I mean, up, which, where the existing is there. Yep. So,
Or go up.
yes,
Okay.
yeah. And so you have the open loft on the second floor in the master bedroom. The open loft is open to the stairwell, so I would say that's 1 bedroom. And then you also have on the first floor, the master bedroom. So they have a master bedroom on the first floor as well. And then they also have the kitchen, and then they have, I believe, an office, so in a family room. So I'm just looking at this. So 1 family room, 2, the dining room is in the kitchen, so I would call that 2. So 1 on the family room. And the dining room, kitchen are open to each other, so I'd call that 2. And then the master bedroom is 3. And then the other bedroom upstairs is 4. And then downstairs you have 2 rooms is what they're proposing. I don't know if that can be enlarged, but that's
So my recollection, and maybe Ellen will have to jump in since we talked about this. My recollection is that ZBA permitted the deed restriction to 2 bedrooms. I think we would perhaps need to verify with them that that was separate from room counts as we would look at it.
Okay.
And so I can write an email, or Ellen could write an email just asking them to confirm that.
I guess for me, one of the struggles I have for this is, like, we sort of look at the last property we just had, right? Where it was like, hey, this is a 4-room house going to 5, that I suspect the square footage of is much, much less than 59 North Main.
It is.
We sort of said, hey, I think getting to 5 makes sense. Getting to 6 feels tricky. And like part of what feels tricky to me for 59 North Main is this is all like in the new construction phase. Like this isn't that you sort of say, well, I've got this house, we finish this as a media room. It's like you're building this house right now, and this is sort of part of the plans in use. And so for me, like, this seems like it's probably, I mean, I don't see the square footage numbers clearly enough to calculate, but it seems like we're saying this is like a 2,500 square foot 2-bedroom that we're now adding more rooms to.
And I thought that the whole point of the 2-bedroom restriction was because this was like, an age limited area, and that the thought being that if you started going beyond the room count as permitted and restricted, that the probability of having children and other, family members starting to live there was enhanced. And so I thought this was sort of also a stopgap check on like, hey, this is supposed to be, for people of a certain age that we're not going to be expecting, large families and school age children starting to reside there. So I thought that was part of the intent of the initial development. Am I wrong or?
It is, but I have the same concerns that it's getting a little too large and then could lead to other issues, especially when part of the EA housing is that the volume assumed to be flowing from these units is less than the 2-bedroom house that we just looked at. But I think because it's a 40B, it might be treated differently. And that's what we should confirm with ZBA, I think.
Yeah, and I'm not for sure. They have 2 units up there that are 40Bs. I don't believe this is one of them.
Yeah, but it's a 40B development. It's the
Okay, I
whole
understand.
package. I think we hit this with the fields at Sherborn,
Okay.
I think. And I'd like to verify that.
I didn't realize it was a 40B. I thought it was considered age restricted.
No, I think it's a 40B because they were the ones that had the issue where at least one of the original plans, there was some part of the waste treatment that they put specifically in one of the low income buildings.
Oh yeah, that's right.
Yes, they were trying to put the well.
Affordable, not low income. Yeah.
Affordable. My
Yeah,
apologies.
they wanted to put the well equipment in one of the affordables, and then they finally put them in the sheds out back.
And I think my other comment or my other reaction to this is, I think on the plan it lists office/loft, and then in the downstairs basement plan, it's also like, oh, this is an office too. And it just is like, God, you've got a lot of offices, and it just feels like far from the intent. And as we look at the scrutiny we did for the South Main project, it just feels like, to be consistent, it's tricky. But again, 40B trumps everything. So I'm happy to do whatever makes sense there, but this gives me pause.
Yeah, that's why I brought it to the board as well. I thought it was a little bit, we're going into 6 rooms, 6 total rooms.
Right.
And that second floor loft is a labeled room, but it's labeled as an office. So we could be if we wanted to call the office loft a room, you're into 7 rooms, on a 2-bedroom septic system, a 2-bedroom facility.
And I'm okay not counting the loft. Like, I think in general, we treat lofts as not rooms, and that passes the gut check. But at some point, it feels like you can't just say, we've built the entire house subterranean. It's 17 deed restricted basement rooms. It's got a 2-bedroom system because it's EA, but it's 6,000. Like, there's some point that it just feels like it's approaching absurdity. And I'm not sure that this one is there, but it's closer than I'd like.
Yeah.
Yes, I agree. So Ellen, we could talk about whether I write it or you write it.
And if you need my help, I can help to assist too.
Okay. But
All right.
I do think because it's a 40B that there's not much.
Right. That's my remembrance of it.
Yeah.
Disappointing as that may be.
Could those
Slippery slope as that may be, I guess.
could the rooms in the basement be deed restricted at all, or?
Well, I'd say let's just find out from the 40B piece, because again,
Okay.
if it's rendered moot by the regulation, then I'm happy to proceed with whatever that set of rules are. And if it's not moot, then I would encourage the builder to participate in the discussion. Because I think
And they were made aware of this meeting, but they're not here tonight.
Yep.
And I believe that the condo documents were supposed to specify that it was restricted to being 2-bedroom. So I don't know if we would have any way to require a deed restriction on top of that condo restriction.
Yeah. Yes.
But we should make sure all that got in place, I guess, is the other benefit of communicating with ZBA, just to make sure.
Okay. Excellent.
Okay.
Good. Thank you.
All right. Let's see. Public health nurse. me see. Oops. Sorry, give me a moment. All right. So the town of Medfield was nice enough to share with us the recent job announcement that they had for a public health nurse. So I just don't want to go through this in detail this evening, but I wanted to point out a few things and ask a few questions of the board as we tailor something more for Sherborn. Medfield is larger, certainly a much larger community than Sherborn. And so, and this was for a full-time position. We're thinking of a part-time position. And I think there's a lot of excellent information in here, but maybe some of it goes beyond what we would do. But we also were hoping to use additional public health nurse support in town to help address our emergency response, both on the planning and the execution side for in town. And am I coming through any more clearly at the moment before I talk a lot?
Yep.
Much better.
Much better.
Okay. Don't know why. All right. Okay, so one is a couple of things. Do we view this role, and Ellen, I might ask you, as whether we'll be supplementing Walpole Natick VNA, or do we think this might replace the VNA services that we have now?
Well, if you were able to get this as a 25-hour per week position, I think it could work on its own. I don't think you would need to continue with the Natick Walpole VNA.
Okay. All right. And so, right, I guess that would be a big question, because 25 hours the town will.
It would be a benefited position.
Right, right. So they're going to have, I'm sure, some comments on that. Okay. So anyway, let's see. In general, is the board agreeable to the concept of having a public health nurse in town to not only do what the Walpole VNA is doing right now, but also to help out on any other tasks that are within the capabilities of the public health nurse? And emergency response is one, certainly, that they could cover. And to offload, basically what this means is offloading some of the tasks that are currently on Ellen's plate, which has been overfull for years. So this would be taking care of some of the extra demands that have been ongoing for quite some time. Could be helping with flu clinic if we choose to do those. This person could work on that.
I would think they would take it over.
Yes.
You may also want to consider, I don't know if it's within this job application, but the need to assist the Council on Aging. A lot of times a public health nurse will interact with the Council on Aging on some of their nursing needs.
Mm-hmm. Right, like the blood pressure clinics and that sort of thing.
Exactly.
Which right now the VNA is doing that with them. And this person could potentially do that. All right, well, you could think about that. I'll just point out a couple of other things is here. We also have food and camp inspector, I thought would be interesting to help out, potentially reviewing the documents that come in.
Yeah, and
for camps.
It's very important for camps, Daryl, because when you're looking through camp health records, many towns utilize the public health nurse to do that work.
So I don't know how many people got to read this before this evening.
And because obviously the biggest objection is going to be that it's a benefited position. And is your main, and what is the reason that we wouldn't, that this is more desirable than continuing work with the VNA?
Because we need more help in town. And whether it's whether it's 25 hours or we make it less than 20 hours, which would be an unbenefited position, is just something we need to contemplate or see what the response is. If we're encouraged to look at it as a part-time unbenefited position, whether there are even any people interested in that.
Darryl, if I can add too, and Ellen may want to put her 2 cents in, because prior to COVID, public health emergency response could take up, I know when I was doing it, it could take up 10 hours a week of my time when I was not in Sherborn, but the other town I worked in. So again, and it showed with COVID that at least we were somewhat prepared, but now we're running into the after action reviews and determining you know, the work that was done and the work that's needed. So that could take up quite a bit of time with this position.
I absolutely agree with that. There's more than enough work that a nurse could do in Sherborn for that amount of time.
Darryl, if you're trying to communicate, we can't hear you.
No, I'm just thinking about what the next step should be on this,
What is
because
the number of hours per week that the VNA is spending with us?
it's been very variable because of the COVID-19.
Yeah, but do we have an average number?
Pre-COVID, Ellen, what would you say? 5 or 10 hours?
Yeah, I don't know.
That we might need that number to present our case, you know, to the advisory board and the selectmen.
Well, it wouldn't really apply because what they've been doing for us now is mostly COVID.
Right.
And
but even we should definitely include the numbers, because obviously COVID-19 has increased the demands on you exponentially, and that number would be helpful for the, you know, to get support.
And please don't take this the wrong way. But one of the reasons that I think it's really necessary is that I'm not going to be here forever. And when I'm gone, if there's a public health nurse, I think the Board of Health will be in a much better position. Because I'm just not getting all of the work done that should get done.
Mm-hmm.
No,
I'm not arguing against it. I think that you do a fantastic job, and you put a huge amount of time and effort in. I was just saying that they might ask us for that number, and if we have it, it might help support this interest.
No, I think that's a good point. We need to talk about what needs taken care of. And the emergency response planning and maintaining the documentation that, you know, huge volume, big, thick binder constitutes our current emergency response plan. And that hasn't been updated in quite a while, and there haven't been meetings recently because fire department is busy, police department is busy, Board of Health is busy, and having someone who can stay abreast of that and make sure that things are up to date and ready to go could be useful across a number of departments in town, because that's really been pushed to the side by other demands of late. Although we did reactivate it for COVID-19 and everyone jumped in and that worked out very nicely. Let's see.
Plus, it
I
would
don't know
be
how people,
data. It would give some objective data for the decision of whether it's a supported or an unsupported position. No, that's all I was thinking.
okay. So Ellen and I can talk about
Pages.
making a list of specific items that this person could do. But one of the things that Medfield has is about public health clinics. So the blood pressure we know is ongoing, the COA. We've talked at various times about whether to even continue the flu clinics, given that it's easy for people to get flu shots at area pharmacies and at their primary care physicians' offices. But does anyone have any particular thoughts about public health clinics and whether for a small town like ours, it's appropriate?
I think it's a good thing for us to do for the community. And I think that it would be a shame if we didn't, even if it's small. I think we should provide it. And I think if a nurse would facilitate that, that would benefit the community.
Do you think it's a good thing because the residents don't have access otherwise, or because it's a chance for the Board of Health to interact with the residents?
Well, I think the Board of Health right now, the majority of the work is enforcing local regulations. And it would be nice if we did some other things and other categories that are, you know, beneficial, perceived as beneficial and helpful and true, you know, clinical public health prevention, you know, disease prevention. And of course, I think this is important. And it's great that it's accessible, maybe more than it used to be, but I also still think that there's a value. You know, elderly people, maybe certain people might have a harder time and might feel and might appreciate that.
I don't mean to be contrarian. I guess I am enthusiastic about the public health nurse, and I think the collaboration with the COA is a wonderful example of, you know, things I think it could be helpful for. The flu clinic, certainly a sustained response to COVID, because I don't think we're almost done with it. Like, I think this is going to continue to be a topic. I think there's some parts that it's worth recognizing, like we're a small Board of Health, and it's sort of different than like the Boston Public Health Commission. Like, I worry a little bit, like for a volunteer board, you know, sort of being cautious about the scope creep, because I think it's tough to sustain. Even sort of what we did pre-COVID was like, you know, felt busy and kind of okay. But I worry if we add a lot of new things, even with the public health nurse to kind of facilitate it, you know, I sort of worry how much can we do. I do think there's a ton of stuff that Ellen does that in the far distant future, when Ellen eventually leaves, like in 20 or 30 years, you know, whatever feels right, you know, thinking about how to replace that position. And I do think that right now, if you sort of look at like what was happening in Dover from their Board of Health, I think they did a wonderful job, but I think there's a lot of expertise Ellen has accrued in a lot of domains that the next person who takes that job probably won't have the decades of experience that Ellen brings to the table, and supplementing it with kind of a clinical background could be a really nice addition to make us a little more resilient.
Are we talking about how to justify this for the advisory board, or are we talking about whether or not we support it?
I think it's both. And I think, you know, 24 hours to me seems like 24 hours a week we're talking, that seems like a lot for our size town. And I guess I agree with Matt, and I would like to have a better understanding of who would be the users of you know, these additional public health clinics. And is it primarily you know, the elderly population, and could this be more sort of through Council of Aging, you know, or other sort of venues focused? Is it right to do this through the Board of Health, or, you know, could we, you know, look at maybe somewhat less hourly commitment to support and augment a lot of the things that Ellen's been doing that might be hard to replicate in, the next person in that role. I just think we need to balance it. And like we said, we have limited resources and we have a lot of other things going on, regarding, adequacy and quality of our water supply and other things. So I'm not poo-pooing it, but I'm like Matt says, we have bandwidth limitations and we just have to
But I don't know what you're talking about, because these are not things that we are adding. These are things that the Board of Health has done for decades. All I'm saying is that I think we should have some objective data for advisory. That's all I'm saying. I'm not.
No. We don't have a lot of big public health clinic beyond the flu clinic. How many big sort of Board of Health sponsored, public health clinics are we really doing right now?
I don't think we're doing any. I mean, I'm just saying we shouldn't take away the flu clinic because there's a value to it. But
I mean, a flu clinic is one small thing though. Like, so that's not 24 hours, like a week. I guess I'm just sort of saying, like, let's look at the some balance of where we want to spend our money. And, is 24 hours a week for this, the best use of our resources that we're going to be allocated, or would we want to have the availability of a consultant to look at other things, maybe along the lines of, the bedrock blasting or updating our regulations. We have a lot of things that we want to do. So we just have to be mindful and selective about where we're choosing to put the resources. That's all mine.
I think that's
Okay. So I think I've gotten a sense that we don't have to focus on public health clinics in what skills we're looking for in somebody, other than perhaps continuing the flu clinic. We still need to decide on that, and working with the COA.
Can I just mention that, yes, you should definitely continue the flu clinic if you are going to continue to participate in the DPH emergency preparedness program.
Yeah,
because a flu clinic acts as a drill, which is required in order to get funding.
Mhm.
So
yeah, 'cause I think we're just, that's a funding source for us. So I don't
Yes.
know what the requirements are for that.
yeah.
So
At a minimum, the flu clinic should continue.
okay.
But
And
then
I
when
could
you
add-
when you look at what the VNA does now is with the Council on Aging, that, I mean, they do public health clinics. I mean, they do blood pressure clinics and other screening clinics. So it would roll in and it would take that funding there.
And if I can add to Ellen's comments, because Ellen and I both participated in Homeland Security emergency preparedness. And one of the things they started back after 2001, September 11th, was noting that we may need to be on our own, town by town, city by city, if something serious like anthrax happens, where you need to inoculate within 48 hours. So that's why the public health nurse is an important facet for emergency preparedness, and the clinics that were being discussed by Ellen are another important facet to make sure your local people are trained to run emergency inoculations that may have to happen in 2 days. So they could actually be a conduit to your medical reserve corps. And it's everywhere in the state that it's starting to fall apart a little bit because COVID took over everything. So that would be another aspect to what the public health nurse could do.
Mhm.
yeah, I think we all agree that there's a benefit to having a public health nurse. I think that we might, so I'm not really sure what we're debating, because I think how we allocate our funds and things are just a routine part of being a Board of Health. So what is it that we're deciding right now?
I just wanted to get some input so that Ellen and I could go through this Medfield example and know which things do and do not resonate with the board in terms of what we need to include.
Well, I mean, I'm a clinician, right? So, and I think we should do all the the clinical work, which is a really good argument to support having a public health nurse. So I don't think we need to I don't think that we should even have
and I guess to me, like things like blood pressure and all these things, no one's saying these aren't a good idea. It's, do we want to, is there such a need in this town to do that as the Board of Health, when, you know, we look at our median income and our median, you know, home price and all these things, that are people able to access some of these other things like, you know, blood pressure checks and other types of things. Again, I'm not arguing that they're not good things to do, but again, if we have a set budget that we have to, you know, comply with, I think the emergency preparedness and the flu clinic, that's one whole set of stuff. Great. But some of this stuff is, you know, sort of additional. And I guess we have to decide what are the most important priorities as a board with private water supply and septic that we need to focus on. And that's all, like going back to what Matt said, bandwidth.
But I thought the agenda item was whether we support the idea of having a public health nurse, and I think we all agree that we do. So what is are we
24 hours a week? It's how much too? Like,
okay, but that's not our decision. I mean, we think it's a great idea. So now we just need to apply and hope we can get supported for that, right? Isn't that what we just?
I think right now we're kind of trying to, Rebecca, I think right now, if I heard Daryl right, I think we're kind of validating kind of Daryl and Ellen's impression that this is helpful, which it sounds like sort of supportive. Then it's a question of scoping and figuring out like what's the scope of where it's helpful. So I think I would echo some of Lisa's point that like there's lots of things that I think our community has access to that many other communities in Massachusetts don't. And so thinking about what are the things that are useful. So I think to Ellen's point, supporting the flu clinic, which keeps us eligible for grant funding, that's a great use of that time. And, you know, for me, the other things I think about is, you know, we'd had some of the alcohol and drug prevention education that's been supported in the past. You know, I sort of wonder if there are other resources around addiction where there may be some other sets of barriers that we have segments of the community that may be less comfortable accessing, and thinking about are there ways we can leverage for that. I think it's probably not like blood pressure checks in a 45-year-old, but I do think there are probably domains that could be helpful. But I think that whenever we do something, we just have to manage the scope to say, like, we're like a pretty small staff in terms of what the board's funded for. And like Ellen's incredibly busy with just the sort of septic and well pieces. And so if we take on new things, my advice would be, we want them to be supported by the public health nurse and sort of not dependent on, you know, the board right now has this many doctors versus this many engineers versus whatever, but to really say like that sort of role is freestanding. So I think
I also think that you're right. I mean, all these things are absolutely true. But I also think that just like any board, you know, the priorities are always set by the chair and the members of the board, and each one of us has our own expertise and our own interests. And so I think those things are going to change every year. And it's not really relevant. I think we should definitely try to get approval to have a public health nurse. I think it's a great idea. So
I think the question for me is, do we feel like the current work being done by the VNA and Ellen, plus perhaps the addition of taking over some work from the camp inspector and potentially catching up on some things we've fallen behind on, is enough to justify 25 hours a week? The sense I'm getting is that maybe it is. We don't need to go out looking for new community health outreach opportunities, because just sort of getting us caught up on the stuff that's fallen behind during COVID, as well as offloading things from Ellen, may be enough to justify the 25-hour-a-week position.
Yes, and
I think the only thing we're missing is a retrospective analysis of how many hours we've had to bill to the VNA. And I think that it would be useful to say prior to COVID-19, this is all we needed. And then after that, we needed X. And that's just objective data that tells us what our demands have been and what we've needed. And that will be really good support for the argument.
all right, so to put everyone out of the misery of talking about this in the abstract, I will, again, work with Ellen, list things out, try to come up with some hours attached to it. The reason I had highlighted just a few things here was to get your input on how you felt about some of these other things that I would say were not, other than this right here, immunization and blood pressure, that we weren't doing a wide variety of public health clinics. So I think I have a sense of where different people stand. Certainly feel free to add other comments, but we'll go away with this starting point. This was merely a starting point for us, and we'll try and craft something that's suited to Sherborn and then bring it back for review. And not, this just came in today, so that's why we didn't have a lot of time to look at it, nor did we. And we'll send it out for review prior to whatever the next discussion time might be. And it might not be the next meeting, it might be the meeting after that. Does that sound okay?
Sounds great.
Okay. And the other thing is a reminder that we're going after ARPA funds for this, because it's one of the things it's supposed to be for, is to help reinforce and improve public health services in towns. An explicit part of ARPA.
By the way.
Oh, again, geez. I don't know. All right. Matt, I'm going to guess that you've been swamped at work. But
I think we can officially take this off the agenda, and when it becomes less busy, we can revisit.
Okay. And then we'll view it as a happy sign that
the world is back on track.
Yeah. All right, Lisa, do you want to talk about the Natick landfill? PFAS results?
Yep, sure. And I also looked into 2 other PFAS related items, the general chemical data, as well as the private well data, but I can certainly start with this. I had Ellen add to the reference documents a couple things that might be helpful for people, which is,
which one do you?
Okay, so there's sort of 2, actually, so more the MCP PFAS amendments, Ellen, I don't know if that's what they're called in the, yes, perfect. So if you can scroll down, Daryl, keep scrolling. I'll tell you when to stop. Yeah. Oh, okay. Go up. Sorry. So right at the top of table 1. Okay. So under, keep going. One more page so that we can show the PFAS. There you go. Okay. Stop. Oh. So scroll down to PFAS. Alphabetical.
Oh, all right.
All right.
Now I know what you're after.
Okay.
Got it.
So in the state of Massachusetts, there's Aquifer Classifications. And what that means is that in Massachusetts, not all groundwater is considered potable water. So in our town, that is the case because we rely primarily on private wells in our town. But in abutting towns like Natick and other towns that have public water supply, there's what's known as a groundwater classification system. So only water that's like part of a delineated zone 2 for a public water supply, or within 500 feet of a private well, and a host of other criteria, is considered what we call GW1, which means that it's considered a either current or potentially potable drinking water source. So that's what GW1 is. For PFAS, they're not considered particularly volatile. They don't like to be in a gaseous phase. They like to stay in the water. So the Gw3 standards don't apply. So we're not going to even talk about them. The other standards that are pertinent from that table, Daryl, if you can scroll back, are what's called Gw3 standards. And basically these GW, can you pull them back up, or do you need?
Yeah, no, sorry, it just,
Okay. So the GW3 standards are intended to be protective of groundwater flowing to surface water. So to streams, to wetlands, to the ocean, to any kind of surface water bodies. And they're intended to be protective of biota, you know, fish or benthic organisms, et cetera, that live in those surface waters. So what happened is Natick had a landfill that was regulated under what's known as a solid waste regulations of Massachusetts. And the landfill was closed out under the solid waste regulations. And in Massachusetts, if something is being, quote, adequately regulated under one set of regulations, like the solid waste regulations, which apply to landfills and landfill closures, they're not necessarily also regulated under the state, you know, Superfund regulations, which are, you know, the Massachusetts contingency plan. So that's basically what Stantec and DP is saying, that for the Natick landfill, which, you know, as we all know, is in very close proximity to the Sherborn line, it was closed out under these solid waste regulations. So even though they have to do monitoring of groundwater and surface water around the closed landfill, that they're considered adequately regulated and therefore don't necessarily start triggering the standards that we're showing on this table, except for certain circumstances like imminent hazards, like if there was an imminent danger to public health or the environment. So what I did is I looked, what they did is they took a bunch of groundwater samples. If you can go back now to the plan, which is the figure in that report by Stantec that you had pulled up. They basically went around the closed landfill, and they have some monitoring wells that they looked at the groundwater quality. Yep. And then they also had some surface water sampling points. And they looked at, of note here, PFAS. Whoop, nope, just stay on that figure there.
okay.
There you go. All right. So you can see, so you see those little hatched circles around the landfill. Those are the monitoring wells where they looked at groundwater quality. And then like see that CFC PFAS 1, the triangles, those are surface water samples. So those are taken in either like wetlands or streams. And so the water in immediate proximity to this closed landfill and under the landfill is not used for potable purposes. So the 20 parts per trillion PFAS 6 standard doesn't technically apply to the groundwater that's right around the landfill. So what does apply to those groundwater monitoring points are what I was explaining, those Gw3 standards. And the only point that had any exceedances of those Gw3 standards was TH8. It had one exceedance. So if you look for protection of ecological receptors, those Gw3 numbers, which you can see there, those are done on a chemical specific basis. So you're not summing the 6 like you are for the drinking water for that 20 parts per trillion. You're looking at each one of those 6 PFAS constituents individually. The only monitoring point in groundwater that had an exceedance of a Gw3, again, for protection of surface water standards, was TH8, which is located on the left side of this figure. See TH8? Yeah. So that had one exceedance of Gw3, not by a lot. The standard for PFAS is 500, and I think it was about 670. So it was above, but not by a lot. But then they also sampled surface water in the wetland, like look at SFC PFAS 1. And, you know, within the surface water samples, there were no exceedances of criteria that are protective of ecological receptors. So there's nothing right now, right around the landfill that is saying like, wow, we have some kind of, really significant and imminent environmental concern. However, what this plan doesn't address is it doesn't really talk about, okay, well, where are the closest private wells that people are drinking from, and sort of looking at the levels on the down gradient edge. In other words, groundwater has a flow direction. It seems like there's wetlands all around. And Tom, I don't know if you researched more about the groundwater flow dynamics here, but typically things flow towards the nearest wetlands and surface water. So, the positive is that I don't think that there's any Sherborn private wells within very close proximity to where these elevated groundwater concentrations are. But because this map doesn't show sort of a broader picture of where all the wells are located, and I know this is something that the Groundwater Protection Committee is working on, which is sort of mapping out where all of the private wells are. I can't really, extrapolate from the data that they took right around the landfill to, what might be migrating towards any private wells, but I would guess that the predominant flow direction is towards the wetlands, which is sort of away from where probably the closest Sherborn wells are, which are probably on the other side and south on 27. So on the other side of 27, they're all like, or further south. But it's not on this plan. So, I think that's something we can take a look at. But, the good news is that when I looked at this relative to, what are the standards that if this was regulated under the MCP that would be applicable, there was only one location at one point that had one groundwater exceedance of the Gw3, and the surface water data didn't seem to translate into a significant, surface water set of concentrations. So that's all I can sort of tell you exactly at this point in time. So it's not horrible. There obviously were some pretty high levels of PFAS. Again, TH8 had the highest total concentration of PFAS. So the good news is I think that's more kind of on the edge that's further away from the Sherborn wells. That might be across 27 or also, I guess further sort of south. But, again, if these are all shallow wells. So I don't have a sense of, what might be happening deeper. Is any of this getting into bedrock fractures, any of that? That's just nothing that was required as part of the landfill closure monitoring plan. So I can't, speak to that. So I can only sort of report on how does this look compared to the standards that would be applicable if this was regulated under the MCP, which it's currently not. And it doesn't look too bad right around the landfill relative to that. But I can't really say beyond that. If this was an MCP regulated site, they'd have to put additional monitoring points, sort of down gradient, and potentially, to the point that they were hitting 20 parts per trillion, just to sort of see how does it look, but they're not. So, we don't have that data to sort of look at further out.
Okay, I'll make just a couple of comments. There are lots of wetlands on this side of 27 and extending down into Sherborn, pretty much all the way to Everett Street. So even though this is where the wetlands are labeled, here, there is a large area there. So in terms of connection, the other...
except Daryl, look at SFC 4 and 4S. Those are practically right on 27, and those are very low.
Okay, so I guess then we don't really have information over time to know if testing was done over a period of time,
Trends and,
does that show where the movement might be?
well, I
So
think
is the general movement to the
to the wetlands, yeah.
northwest? Is it to the southeast? Big difference. Be nice to know that. Or could it have to do with when the materials were deposited in which part of the landfill, as to what the levels are? So all that's hard to know, but still the idea that if this is in the overburden groundwater, when it meets the bedrock, and if it encounters bedrock fractures, then where is it going?
Right.
And so I guess with the kinds of levels that are shown, I'm not comforted by the fact that it hasn't exceeded the Gw3 standards, because where was a really nice
the
chunky one?
8 was the high one. The TH8 was the highest, but I mean, again, even if this was regulated under TP, if it's not classified as a GW1 aquifer because it's not within 500.
Oh, I understand that. I understand on the regulatory level, but from the perspective of us watching out for what might be en route to Sherborn wells, having something, this has to be multiplied by 1,000 to get to compare to drinking water standards. And I know it is not yet known to be drinking water, but when you look at something that's 9,000,
no, it's
three,
like
930,
10,
100,000, 930 compared to 20. It's not going to take a lot of that to get mingled with other waters.
Right,
push it up over a drinking water standard.
Right.
So
except it also could be all, the dominant flow is going to be typically horizontal versus vertical, and especially in close proximity to wetlands, it could be all sort of, or the majority, upwelling into the surface water in the wetlands. So it might not really be, migrating. Again, we don't have the answers to those questions. And this sort of piggybacks on, I looked into all the private well data from Sherborn. I also looked at the general chemical data on PFAS, relative to Sherborn. And, I guess the problem is that we had 31 wells, private wells, that were sampled in Sherborn for PFAS through the voluntary, program. And we had exceedances of the 20 parts per trillion in 5 out of 31 of those wells, which was sort of surprising to me. That's a lot, in my estimation. So we had, we had 12 wells that had nothing detected. That's awesome. But we had 19 that had at least some detection. And of those 19 that had detection, 5 had at least one sample that was above 20 parts per trillion. So we didn't have anything that was an imminent hazard. We had nothing, the ones that exceeded 20 barely exceeded 20, they were 22, 23. And the 20, just so everybody understands, is a very protective standard. I'm very comfortable where Massachusetts has set this number. It's, they looked at the lowest and no observed effect levels, and then they added uncertainty factors and safety factors of 300 times. And the effects were things like typically like, reduced birth weight in, mice progeny, or maybe slightly elevated liver weight. So, these are what I would consider more subtle types of effects. And like I said, they added a bunch of safety factors to be very protective of even sensitive subpopulations in people. So that 20 number, that's a very, very conservative, protective number. But that said, we had 5 people in our town that I don't know where they're located because, for confidentiality reasons, they're just numbered as, sampling points 1 through 31. I don't know where they are. I don't know if they're close to this landfill, Daryl, or if they're on the opposite side of town. So, that's one issue. But you know, those people probably want to put point of entry treatment systems on, you know, their wells to reduce, you know, with, you know, GAC, granular activated carbon, or, you know, there's a couple other types of resins and things that will absorb the PFAS very effectively, reduce it to non-detect in their homes. But those cost like $10,000 to $20,000. And then you also have to monitor for breakthrough, and then you're going to have to put a deed recording. So there's a lot of, you know, costs and repercussions associated with that, that it's very unclear on what kind of assistance the state is going to be providing, if any, for people who need to, you know, maybe consider putting point of entry treatment systems on their wells. And it's very unfortunate that, you know, I think it's great for people who are interested, who got the postcards, who decided to understand what levels they might have in their wells. But now it's kind of, okay, now what? In terms of their liability, in terms of selling their homes, in terms of, you know, putting these treatment systems on, and then doing the associated monitoring, and then ultimately disposal of the spent carbon, which isn't cheap, you know, to get rid of it. It has to be incinerated. You know, I guess I just don't understand what the implications are to these homeowners and what kind of assistance DEP is going to be, you know, providing to people.
Well, and it was interesting when we first met with them and expressed our concerns about what would happen
exactly
if things exceeded the standard, and they truly, or at least they said, they just didn't think that was going to happen.
Yeah, they were very,
which was surprising to me, but and I think maybe they've been surprised by the results that they found.
We were sort of, I will say, I looked at a lot of the data that was collected. 60 towns out of the 85 have had, you know, so far have had this, you know, voluntary select monitoring. Like personally, I didn't receive a postcard. Maybe that's because I was such a noisy person at the meeting we had with them. But, you know, they were trying to get good spatial coverage, you know, from different parts of town and et cetera. So, you know, it was only a subset of us who even, I guess, were invited to get the well sampled. And then obviously only a small portion of those people elected to proceed with the sampling. But, you know, I guess I just, as a board, you know, in terms of what kind of assistance we can provide, and, you know, what it is a town interested in helping support these people or not, or is there going to be a fund available, or can we advocate to DEP to have them, you know, try and set up some kind of funding mechanism. But, you know, compared to a lot of the other towns, we had, for the, you know, number of people that had well sampled, we had a pretty high rate of homes above 20 compared to most other towns. And just for compare and contrast, Dover only had 14 people who had their wells sampled versus our 31, and they had 0 above 20. None, not one. So I'm just putting that out there.
Something else to, just when you're talking about how to help these folks, I'd like to point out that I viewed this whole program, or I think it should have been viewed as, this is not to be viewed as contamination that is tied to that one individual well. Those wells were merely access points to look at regional groundwater conditions. And so what I'd want people in town to think about is not, oh gee, you know, my poor neighbor who had a high level, guess what, we're all in this together. And if it was found in some, and yes, the numbers are going to vary from place to place, but a lot of PFAS was identified in most of the wells that were sampled. So we should all assume that there's something in our wells, and how we're going to address this, I have no idea. But maybe the Groundwater Protection Committee, and I think Tom Trainer, and I don't know who else is on, might want to speak to that, since I know they've been putting a lot of time into this.
Cheryl, this is Tom. Can I
speak?
Absolutely. Yep. Please.
Thank you, and thank you, Lisa, for that excellent overview of the landfill. We have been on the Groundwater Protection Committee last couple of months, started getting this information and started trying to digest it, and we are quite concerned about some of the things we're seeing. And I won't go into too much detail, but you've hit on two things. One, the landfill, and I would say landfills, right next to that is the Sherborn landfill, which unfortunately we haven't tested yet for PFAS migration. You've mentioned the residential well survey program, which was public. It was open to not only people that got the 200 postcards. The Groundwater Protection Committee did put out press releases last spring and did put on the town website notice of that. So we're concerned about those high values. And as Lisa mentioned, Sherborn seems to be on the high end of the over 20 part per trillion rate. A couple other things that hasn't come up yet in tonight's discussion. One is the public water supplies in town. We have one water supply that's very close to 20 part per trillion and is on notice from the DEP to go to a monthly sampling, a higher rate of sampling. That's the well at Town Hall, so that's a concern. And then we have of course the other big site at our borders, General Chemical, that we know has very large documented pools of PFAS at that site. But one question the Groundwater Protection Committee has right now is, thanks to modern technology, we're getting all this data now. We probably should do more testing. How do we protect our residents, or how do we communicate with our residents this information and digest it? And actually, to finish, would it be okay if I shared my screen? I'd like to show one map, and this goes to just that landfill discussion. You see this map?
Yes.
Let me orientate people. What we were just talking about, can you see my cursor?
Yes.
Yeah, there's Route 27. There's the golf course, which is this closed landfill. Just south of it is the Sherborn landfill. And then in the map Lisa was showing, essentially circled that golf course, and that test well number 8 was right around here. To add complexity on top of complexity, and talking about surface water and groundwater flow, the watershed divide comes right through this area. But in discussions I've had with my hydrology friends and with the Mass DEP, the general sense is the flow from this wetland just to the northeast of the golf course flows in a tributary stream through this pond just north of Meadowbrook Road into Coarse Brook, that then flows north into Natick. So that's the general flow of anything existing in the wetlands, and assume the general groundwater flow. However, on the other side of the watershed divide, you see this purple line? That happens to be Indian Brook, and Indian Brook flows down to the Charles. And so, the testing points from the eastern side of that area, the assumption is surface water and groundwater is flowing that way. So that's one thing. And just the second and final point I want to make on this map. You see on the far left side, I've got the general chemical site highlighted. There, the general flow offsite is believed to be to the south and east, and Course-Brook intercepts, assumed to intercept some of that. And then Course-Brook again flows north
Towards
into
Natick,
Natick.
yeah. Mhm.
So again, I haven't measured any distances. Lisa, you mentioned 500 feet from residential wells. All these little rectangles are homes. And so you have a plume coming from this direction and a plume coming from that direction. And so we have concerns about that.
Yeah, if I could just say, Tom, though, I did look at the general chemical report, and and again, like we said, a lot of the discharge is thought to be to Course-Brook. And in general, the levels, so the good news is the bedrock well cluster closest to like Coolidge was non-detect from general chemical I'm talking about. So that's like right kind of near the brook and near, within 500 feet of a private well from the general chemical site. So that was non-detect. So that made me happy. And that was sample for PFAS. And in general, it looks like obviously the highest levels of PFAS or general chemical are really closest to the source area. There's generally a decreasing gradient with distance from the general chemical, former building proper and where DEP is having the remediation done. There were some detects in Course-Brook and a couple of shallow, very shallow, like 2 to 14 feet below ground wells. But in general, the deeper wells were less impacted, and certainly the well cluster closest to Sherborn and the Sherborn private wells was non-detect. So, there were detections of PFAS at general chemical, but to me, they actually seemed a little bit less of concern than the landfill, just not only in terms of concentrations, but in terms of distance, and what I observed as decreasing gradients and the likely, sort of interception of at least a significant portion of the groundwater, hopefully from general chemical upwelling into Course-Brook and flowing, like you said, towards Natick. So I feel like certainly general chemical, I'm not saying it's great that it's there, but I also feel like we have a lot more data and a lot more data points, including those proximate to wells, whereas for this landfill, we don't have the benefits of that. So that's, to me, there's a lot more uncertainty associated with the landfill than general chemical. There's just much more data from general chemical.
No, I definitely take your advice on that. And actually, going back to the Sherborn wells from the residential project, these are actually those well numbers,
right,
that Lisa mentioned, and the PFAS 6 values. I have the addresses, and I won't share them publicly here, but I can tell you 2 were in the general downtown area, and 1 was in the general area of the map we were just on, and 2 you would never imagine.
Interesting.
Yeah.
And of those 5, to be fair, the confirmatory samples of 2 of them were below 20, not by a lot, 19, 17. And again, these are tiny, tiny numbers. I don't want people to lose perspective on that. These are, we are dancing on the head of a pin with these numbers. These are parts per trillion. So, the difference between 23 and 19, it's in my view, that's the same number. So I'm
Yep.
still counting, you know, like
Yep.
I would still say it's, you know, it was above 20 at least once. 20 is a tiny number, but nonetheless, we had 5 that had at least one hit above that. And, you know, I thought that was kind of concerning.
And actually, the town center well that I mentioned was the town hall well. The last several months, this has been the pattern, and that also should be a concern of the town.
Yes, right. It's right below.
Yeah.
Barely.
right.
Yeah.
Yeah. So thank you. I don't, you know, I don't want to take up any more of your time, but if you have any advice for the Groundwater Protection Committee on where we should head with our focus, please let us know.
Sure. Thanks, Tom.
Yeah, thank you. And Lisa, okay. All right. Does anyone else who's attending have any questions about, answerable questions about PFAS?
Yeah. Yeah. Let's
Which
keep
not
it.
many are that answerable yet.
Right.
Thanks so much. Both.
I just want to acknowledge the reassurance I feel as you guys are, like, you're clearly such an expert in the space, Lisa, and, you know, as something that's outside of my comfort zone as a resident of Sherborn, I'm just like, oh, good, I'm glad somebody knows what's going on, because I'm, you know, the COVID stuff feels easier, and this.
No, well, it's all your niche. So thanks for taking care of all the COVID stuff and the school stuff that you and Matt have been dealing with. That's been, you know, and Ellen, that's been quite an effort. And I'm just thankful we have so many, you know, well-versed experts on this board.
And now let's approve the food permit for One Bite Sweet.
Okay. Let's see, what was the other one? Disposal works. All right, so are they both renewals?
Yes, they
Yes.
are,
All
Darrell.
right,
and I
so,
recommend that they both be approved.
okay. So do we have a motion to approve the 2022 disposal works installer permits for both DJ Morris Contracting of Sudbury and Mayo Excavating?
Moved.
Second.
Discussion? Darrell, I.
Matt Beavers, aye.
Lisa, I.
Rebecca Honeywell, aye.
Matt Vitale, aye.
Okay, and do we have a
That
motion
was
to?
conditional to a pre-construction conference, correct?
Yes, thank you.
Thank you, Ellen.
Let's see, do we have a motion to renew the food establishment permit for One Bite Sweet,
So moved.
subject to a sodium posting?
Seconded.
Any other discussion? Darrell, I.
I heard it, Darrell, aye. I think, Matt, you're up.
Oh, okay, I didn't hear it. Sorry. Matt Beavers, aye.
Lisa, I.
Rebecca Honeywell, aye.
Matt Vitale, aye.
Okay, and then we had the VNA invoice. Did people see? It was surprisingly small for December, 8 hours at $440 for the COVID-19. Do we have a motion to approve that invoice for payment?
So moved.
Seconded.
Any other conversation? Darrell, I.
Matt Beavers, aye.
Lisa, I.
Rebecca Honeywell, aye.
Matt Vitale, aye.
We received the minutes for the January 5th meeting. I think I had the tiniest of changes. And anyone else? Have people submitted what they need to?
I also sent a trivial change to Ellen.
Okay, so do we have a motion to approve the minutes as amended?
So moved. And how should, for folks who aren't there, I can't remember, did they abstain or can they?
It's possible to vote in the spirit of it.
I was gonna abstain.
You can do either, yeah.
I need to abstain as well because I wasn't there.
Okay,
Sounds good.
So-
So I think, Daryl, you had a motion, I'll second.
okay. And so Daryl, I.
Matt Beavers abstains.
Oop, ditto.
Rebecca Honeywell, aye.
Matt Vitale, aye.
Okay, and agenda for the next meeting?
I feel like
Any-
Kelvin will still be there.
Yep. Probably correct. And I'll wait to see how far we get on the visiting nurse. Not public health nurse, excuse me.
An idea of when we might, should we make a plan for when we might start to address some creation of regs for other than a single family house on a parcel? Since we have multiple examples of this challenge that is not addressed in our regs.
Well, if you'd like to pull something together,
Is that something that you think is worth putting on our agenda for discussion?
I think there are a few things that we need to do for our regs in general. And if you have suggestions, I would write them out and give us something, talking point.
Sure, I'd be glad to do that.
So if other things come up, let Ellen know. And we'll see what evolves for the next agenda.
Sounds good. Did we
So
finish?
I believe so. And so do we have a motion to adjourn the meeting?
So moved.
Seconded.
Daryl, I.
Matt Beavers, aye.
Lisa, I.
Rebecca Honeywell, aye.
Matt Vitale, aye. Have a good night, guys.
Night,
Thank you,
everybody.
guys.
Everybody.
Bye.